Okay, so good morning, everybody. My name is Enriqueta Felip. I'm medical oncologist based here in Barcelona and one of the co-chairs of the meeting. And it's an honor to be here and welcome you to this press conference. So we have just finished the plenary session for really important presentations. We have discussed tumor-agnostic tumors, then tumor biomarkers for immunotherapy. We have discussed the possibility of cure in metastatic lung cancer patients, and finally, also importantly, what could be the contribution of artificial intelligence. So now today we are going to highlight one of the most important presentations of today's meeting, and we would like to start with Dr. Govindan. He will present at 10 a phase 1 study of safety tolerability of a new compound, AMG 510, novel KRAS G12C inhibitor.
Thank you. Good morning. We'll be formally presenting the results of this phase 1 study in about 15 minutes, so I'll just go over this. These are my disclosures. And just to set the stage, lung cancer is increasingly seen as a disease with multiple subtypes, including one of the important types, KRAS mutant lung cancer. And there are different kinds of alterations in the KRAS gene, and one of the most common alterations we see in lung cancer is the alteration called G12C, where the KRAS protein gets overactivated and ends up resulting in excessive proliferation of the cancer cells, and that is a fundamental cause of cancer in about 12 to 13% of lung adenocarcinoma. And unfortunately, this particular group has been very difficult to target so far. And a few years ago, there were breakthroughs made in the medicinal chemistry and the biology, and AMG 510 represents one of the first novel, first-in-class small molecule that specifically binds to the mutant protein of the KRAS, as you can see here. And this is the mutant protein. This is the drug AMG 510. It binds to this, the cysteine component of that. It irreversibly locks it in the inactive state, so that KRAS activity is restrained. And this is very, very specific and customized for the mutant protein, and therefore we expect fewer normal tissue toxicities. And the highlight of this is a phase 1 study, and I just want to say a few things in the interest of time, that this is a phase 1 study. The very first patient went on this study just about a year ago. And all these results that we accumulated have come on just within a year of research. And we'll be focusing our presentation on the lung cancer cohort. This is a broad-based study, included not only lung cancer, but cancers, colorectal cancers and other cancers. And what we see here is that in a small number of patients, but a fairly good number for a phase 1 study that has gone on only for a year, in 34 patients that are evaluable, and 34 patients that the subject of this talk, and 23 patients were evaluable. 96% had disease control, and more importantly, about half of them had partial responses, which is a hallmark of activity of a drug. And we did 4 different dose levels, and starting with 180 milligram, going up to 360, and 720 and 960. And it turned out we decided that 960 milligram is the phase 2 toxicity, phase 2 dose. And at that 960 milligram, the evaluable patients, about 13 of them, were looked at as of July 2019. And we can see the response rate of about 54%. And strikingly, 100% had disease control. In other words, nobody had disease progression on the first scan. As you can see here, many of them had a decrease in tumor size. And how durable are the responses? The important thing is about 8 of 11 patients who had partial responses at various dose levels were still on the study. And the same with stable disease. 8 of 11 patients who had stable disease in the first scan continued to be on the study. And as you can see here on this, the partial responses happen fairly quickly, as we come to expect with targeted therapies, and many of them are ongoing. In fact, about 5 patients or so are nearly 6 months or longer on this. One of our own patients with a partial response is doing extremely well, going on for more than 8 months. And this is clearly a very encouraging set of data. And other important point here to look at, we saw responses at all different dose levels, but we have the most experience with 960 milligram dose level. And as was expected of the drug design, the toxicities were very minimal. And with all these studies, especially in a sick population like lung cancer, you would expect to see a lot of adverse events. And about 76% had adverse events. Most of them are disease-related. But the most important column is this here. A third of them had adverse events, but mostly they were grade 1 or 2. And nobody had grade 4 toxicities, which is a severe form of toxicities. And these numbers are extremely reassuring. Nobody had dose-limiting toxicities. No patient had serious adverse event, fatal adverse event, or adverse event leading to discontinuation of therapy, showing that this drug works the way it was intended to, very specific for the G12C KRAS mutant disease. In summary, I would say that for a study that has gone on for just about a year with about 34 patients with the early look, these data are very encouraging. The activity is quite striking with 54% response rates, and the early indications are that these responses are probably durable. Only time would tell. The toxicity is extremely minimal. The most common toxicity attributable to the drug seen in a couple of patients, but nausea and diarrhea, very easily manageable. And the phase 1 and study is ongoing with expansion cohort, and phase 2 monotherapy is ongoing as well.
Thank you. Any question for Dr. Govindan? No. Thank you. So the next presentation that, yeah? Sorry. Sorry? Oh, yes, yeah. Next presentation will be done by Dr. Risby. He will present the mutations associated and sensitivity of resistance to immunotherapy in the MYSTIC trial. So, yes, also presentation for today.
Okay. So the MYSTIC trial, as you know, was so the MYSTIC trial was a phase 3 trial comparing durva-tremi versus durva versus chemotherapy and we analyzed a subset of patients with high TMB using the 20 mutation per megabase threshold and found significant improvement in response, PFS, and OS. What we also did as part of our exploratory analysis, looking at specific mutations that have been implicated in sensitivity and resistance to chemotherapy, as well as prognostic factors, and focused on the tumor suppressor genes STK11, KEAP1, and ARID1A. And the analysis was performed using the Garden Omni assay. This is a plasma assay using a 500 gene panel with a 1 megabase footprints, and samples were evaluable in 943 cases, and we looked at survival outcomes associated with these mutations. So what we saw was that both KEAP1 and STK11 mutations were associated in all patients. So really these are all patients that were treated both either with chemo or with IO with worse outcome in terms of survival, with the KEAP1 mutations doing much worse than wild type for KEAP1, and similarly with STK11 mutations versus wild type. ARID1A, on the other hand, really had no impact in terms of mutation versus wild type for ARID1A on this analysis. In terms of response to therapy based on mutations, all mutation evaluable patients, again, consistent with our knowledge that KEAP1 and STK11 are sort of bad actors in terms of lung cancer outcomes. The response rates to whether were less overall with KEAP1 STK11, whereas ARID1A seemed to do a little bit better with the mutation. When we look at chemotherapy, again, KEAP1, STK11 mutations did worse, and ARID1A did about the same. Similar findings were seen with durvalumab, where the outcomes were less favorable with the mutations. Interestingly, with the durva-tremi combination with the ARID1A mutations, they seem to do much better with a response rate of 51%. Intriguingly, the KEAP1 STK11 mutations did seem to fare a little bit better in terms of response rate versus chemotherapy or durvalumab with the combination of durva-tremi. Again, the numbers are small, so it's hard to make too much of that. Looking at the outcomes for the specific cohorts, comparing KEAP1 mutant versus wild type, and the bottom panels are KEAP1 wild type patients treated with either durva versus chemo or durva-tremi versus chemo, and the outcomes seem pretty similarly. And again, for durva versus durva-tremi chemo, the outcomes seemed fairly similar, although there did seem to be some tail on the curve with the KEAP1 mutations receiving durva-tremi with a hazard ratio of 0.79. For the STK11 mutations, again, looking at the bottom panels, for the wild-type population, there's really pretty similar outcomes. Again, for the mutations, the durva versus chemo did seem to do a little bit better with a tail on the curve, and that was also seen with durva-tremi, so there seemed to be some possible effect with IO in these patients, although when one looks at the overall survivals, they still continue to be fairly poor. ARID1A mutations are shown on the bottom, and then really no difference. Again, the key finding here is really the ARID1A response in the durva-tremi patients, where we have a pretty impressive response rate, as well as overall survival in this patient population. So I think the take-home message really are these STK11 KEAP1 mutations are prognostic for OS. They're relatively common mutations. They're sort of third and fourth most common mutations in lung cancer after P53 and KRAS. They do influence outcomes and need to be factored and considered into our analysis of TMB and other outcomes in lung cancer. ARID1A patients were about 10% of the population, and they seem to do particularly well with durva-tremi, and I think these exploratory analyses can help us think about how to use TMB and outcomes in lung cancer patients in future trials.
Thank you. Questions or comments for Dr. Rizvi? No? So, thank you. So the next presentation for today, important, is the Checkmate 817 with Dr. Barlesi, that will analyze nivolumab plus ipilimumab in patients with special populations, including ECOG performance status of 2.
Okay, thank you. Then the Checkmate 817 is a study assessing the activity and the safety of the first-line nivolumab and ipilimumab in patients with ECOG PS2, which represent approximately 60% of our patients, or other specific population with advanced non-small cell lung cancer. Here are my disclosure. Then here is the study design. The Checkmate 817 studies recruited stage 4 or recurrent non-small cell lung cancer without any prior systemic therapy and without any actionable alteration, especially EGFR and ALK. And those patients were separated in 2 different cohorts. Cohort A for patients in a good shape, ECOG performance status 0-1, which are the usual populations included in clinical trial, 391 patients, and a cohort for specific patients population, either the patient with an impaired performance status of 2, or a patient with a good performance status but a comorbidity. And with comorbidity, we included asymptomatic untreated brain mets, hepatic or renal impairment, or patients with HIV. And those patients received the combination of nivolumab at a flat dose of 240 milligram and ipilimumab at a low dose of 1 milligram per kilogram every 6 weeks for the ipilimumab and 2 weeks for the nivolumab. And those patients were treated until disease progression on acceptable toxicity for up to 2 years. The primary endpoint was to look at the safety and was the grade 3-5 treatment-related selected adverse events and immune-mediated adverse events, and the secondary endpoints were quite classical. And here are the main results of this study looking at the presentation we will do this afternoon. It's the summary of the safety. On the left, in gray, you have how was the safety in the good general status patients, the cohort A. And you can see that 77% of the patients reported any treatment-related adverse events. And for the grade 3-4, it was 35% of the patients. On the right, you can see that for the global PS2 or patients with comorbidities, the safety was clearly at least comparable, even a little bit lower. 67% of the patients presented any treatment-related adverse event, and 28% presenting with a grade 3-4. If we look more specifically to ECOG performance status 2 or patients with other kind of comorbidity, you can see the features are exactly comparable. 63% of the patients with at least one treatment-related adverse event and 26% of the patients with a grade 3-4. And it's an important piece of information. It means that for those patients with ECOG performance status 2, this regimen is as safe as it is for the general populations. The treatment-related adverse events leading to treatment discontinuation were also comparable, and treatment-related deaths were hopefully very low in both cohorts. Those results made put in perspective with the other data that we have. Of course, it's cross-trial comparison. You know that we should do that very carefully. You have on the left a summary from the Checkmate 817, and on the right, you have the data that comes from other trials with the same combination, the Checkmate 568 and the Checkmate 227, and you can see that it's exactly comparable. Then clearly there is no specificity in this study compared to what we get with the other information. And here is the activity, the efficacy of this combination in this specific population. You can see on the left the response rate, 24% of overall response rate for this specific patient population, 19% for ECOG performance status 2, 37% for the patients with other comorbidities. And very excitingly, you can see that the 1-year duration of response in this specific population was 57%, which is a result which is really appreciable in this frail patient population. On the right, you can see the progression-free survival. The median was 3.9 in the global population, with a 1-year progression-free survival rate of 26%. If we look now at the impact of the biomarkers on the activity in those specific populations, I would say that as expected, patients with tumor showing the highest PD-L1 expression, more than 50%, and patients with the highest TMB, more than 10 mutations per megabase, experienced the longest progression-free survival, with median of 9.6 for the highest PD-L1 expressor and 8.3 for the highest TMB expressor, and a 1-year progression-free survival of 46% for those patients with the highest PD-L1 expression and 42% for those patients with tumor showing the highest TMB value. Then the key messages are that in this single-arm, non-randomized study of flat-dose nivo and low-dose ipilimumab, we had a consistent safety profile compared to a general ECOG performance status 0-1 population, those patients that are usually included in registration trial. And including those patients with ECOG performance status 2, which are usually excluded from registration trial, and we have very few information for these patients usually. And this safety profile was clearly consistent with prior studies using weight-based nivo. Nivo-IP show encouraging clinical activity in this population, 24% of response rate. As expected, unfortunately, globally, the outcome of those patients were lower compared to the patients with a better general status. But despite this poor PS and these comorbidities, those patients achieved durable responses with nivolumab and ipilimumab with a 1-year duration of response of 57%. Thank you.
Thank you. Any question?
Fabrice, did you do an analysis of that lucky group that had high PD-L1 and high TMB? I realize it's very small numbers, but it'd be intriguing to see
it's
what
a small
PFS.
number. We had the TMB value only for 40% of the patients, as you know, when it's not done prospectively. Then I think we will be able to provide with this information, but it will represent very low patient population.
Fabrice, in your opinion, do you think that people with PS Fabrice, in your opinion, do you think that patients with PS2 or other special populations should be excluded from clinical trials?
I think this study is one of the only one prospective study looking specifically at this patient population, and I think we know that for oncogenic addicted tumors, probably PS2 should not be included in the clinical trial. Probably this study provide an insight that those patients may now be considered for some trial where the safety profile has already been, I would say, defined, assessed in a more in a better shaped population. But it's really difficult because it's an heterogeneous group. Then I think that we should try to perform maybe specific studies for this population, at least at the beginning of the development of new drugs or new strategies.
Thank you, Fabrice. So we have discussed a lot of TMB, and we have in this meeting two very important studies that will analyze TMB in patients treated with chemo plus immuno. The first one, Dr. Langer, will present the Keynote 021 results on TMB.
Thank you, Enriqueta, and thank you all for being here. So my talk later today will be on TMB and outcomes for carbo-PEM with or without Pembro for non-squamous non-small cell and analysis of Keynote 021. My disclosures. Mouse is not cooperating. There we go. As you're well aware, TMB has been widely evaluated as a biomarker for immunotherapy in advanced non-small cell and may identify patients who are more likely to respond to immune checkpoint inhibitors. We have very limited data on whether TMB has any value as a biomarker for chemo, either given alone or with an immune checkpoint inhibitor. The phase 1/2 Keynote 021 study was the first study to show the efficacy and safety of the anti-PD-1 immune checkpoint inhibitor Pembro given in combination with chemotherapy. And so we performed an exploratory analysis of Keynote 021 to determine if TMB might have value as a biomarker for PEM and carbo given either alone or with pembrolizumab. Just to remind you, the study designs, we assessed TMB by whole exome sequencing of tumor tissue and matched normal DNA, and this is referred to as TTMB or tissue TMB. Cohort C included 24 patients, 12 of whom were in the TMB analysis. Basically, Pembro at either 2 mg per kg or 10 mg per kg in combination with PEM carbo in treatment-naive non-squamous non-small cell in the absence of any activating mutation. Cohort G was much larger, randomized phase 2 of the triplet combination with a flat dose of Pembro at 200 mg every 3 weeks versus PEM carbo alone. Again, the same eligibility. We performed one analysis to assess whether tissue TMB as a continuous variable was associated with outcomes for Pembro plus chemo and with outcomes for chemo alone. And we performed a second analysis to assess whether the response rate differed in participants with TMB high versus low tumors who were treated with the 3-drug combination. You can see here the demographics are actually fairly well matched for both the TMB evaluable population and the total population, and response rates were closely matched. In the TMB evaluable population, response rate for the Pembro combination was 66% versus 38% for chemo alone, and for the total population, 63% and 31% respectively. There was no association between tissue TMB and efficacy for Pembro and chemo or for chemotherapy alone, whether we look at overall response rate, progression-free survival, or overall survival. Nor was there any association between TMB and PD-L1 with a p-value of 0.34. Roughly 48% had high TMB that was defined as 175 mutations per exome. The response rate for the triplet in that group was 71%, and low TMB below 175 mutations per exome, 52% of the overall group. Their response rate was 61%, so no difference in outcome based on TMB status. So tissue TMB assessed by whole exome sequencing was not significantly associated with efficacy for pembro and combination pem-carbo or for chemo alone as first-line treatment for patients with metastatic non-squamous non-small cell, nor was there any significant correlation with PD-L1 expression. Response rate with pembro and chemo is high in both the TMB high and TMB low subgroups. Obviously, an analysis of much larger data sets is needed to assess whether the benefit of pembro and chemo relative to chemo alone differs in patients with either TMB high or TMB low. And my presentation, obviously, is the appetizer, the hors d'oeuvre for Dr. Garacino's much larger presentation.
So, yeah, thank you. If you agree, we can discuss together after Dr. Garacino's presentation.
We'll be going in the same
Exactly,
sequence, yes.
So perhaps, yeah, you present first, and
Okay, and
then
then
we
we
will
can do the
discuss together.
questions, sure.
Okay, because it's the same. Thank you. Dr. Garacino will present TMB, but in the keynote 189.
Okay. So good morning, everybody. I will be the dessert, and I will present you the end of the story of Keynote 189. Here you have my disclosure. Okay. Keynote 189 is the phase 3 randomized clinical trial. It was a randomization 2-to-1 to receive either the combination of platinum pemetrexed and pembrolizumab and the platinum pemetrexed alone. It has already demonstrated from the first interim analysis a benefit in terms of overall survival, progression-free survival, and response rate, and this benefit was irrespective by PD-L1 status. As it was mentioned before, there are data suggesting that TMB is a good biomarker to select perhaps patients for the single agent or for the combination of anti-PD-1, anti-PD-L1, and anti-CTLA-4, but no data were available until now for patients treated with the combination of chemotherapy and immunotherapy. For these reasons, the objective of this analysis is to evaluate the benefit, the clinical benefit of the tissue tumor mutational burden determined by the whole exome sequencing in the population of the Keynote 189. As you can see here on the left, 616 patients are in the overall trial, and 293 patients were available for the analysis of the tissue tumor mutational burden. The main reason of the attrition were the small amount of the tissue sample to allow a good quality of DNA to test the tumor mutational burden. As you can see, the overall survival, the progression-free survival, and the response rate of the overall population resemble the overall survival, the progression-free survival, and the response rate of the tumor mutational burden available population, suggesting that this can be a good population to draw some conclusion for the tumor mutational burden. We performed two types of analysis. In the first analysis, we analyzed with a pre-specified cutoff the TMB analyzed as a continuous variable. And as you can see, there is no benefit of TMB for the selection of the patients in terms of response rate, progression-free survival, and overall survival. And again, there is no association between the tumor mutational burden and PD-L1 expression. They are two independent factors. Moving to the results, we presented the results for cutoff with 175 and for cutoff 150. They are two pre-specified cutoff corresponding in a pan-cancer data set to potentially to the cutoff of Foundation 1 of 10 and 13. Here you have the results for the cutoff of 175, 13, and you can see that we can find the same point estimate and the same reduction of the risk of death for patients treated with chemotherapy and pembrolizumab and for chemotherapy alone. The same results, consistent results, are found also for progression-free survival and overall survival, where you can see that the combination of chemotherapy and immunotherapy performs in the same way in TMB high and in TMB low. So in conclusion, the tissue tumor mutational burden assessed by whole exome sequencing is not significantly associated with efficacy of pembrolizumab pemetrexed carboplatin, is not significantly correlated with PD-L1 expression. Pembrolizumab chemotherapy had a similar overall survival, progression-free survival, and response rate benefit in both the TMB high and the TMB low subgroups, and our data suggests that the tissue tumor mutational burden may not help select patients who would have better outcomes with the combination of pembrolizumab and chemotherapy given as a first-line therapy for metastatic non-squamous non-small cell lung cancer. Thank you.
Thank you, Alina. It seems we have a clear answer, no, to the question if TMB is able to predict those patients who receive chemo and pembro. Okay. Questions for Dr. Langer and Dr. Agarassino? Please.
Charles Bankhead, MedPage Today. I had a question for Dr. Agarassino and for Dr. Langer. What do these two studies taken together have to say about who should be evaluated for TMB and who shouldn't?
I'll start first, and then Dr. Agarassino can amplify, perhaps. I think it's still an investigational marker, personally. From my own perspective, just as a clinical researcher, I think the TMB approach to TMB can be divided into two groups, the TMB cultists and the TMB skeptics. And I would group myself in the latter, although I still think it has a potential role. We haven't figured it out. I think we have to, it certainly would not be used, at least not yet, in therapeutic decision making. So while I like to know it, I'm not sure I would make a decision yay or nay for chemo or pembro yet. I do wonder, though, if, and that's why I asked the question earlier about high TMB and high PD-L1, is that a group that may selectively do well, particularly well on immunotherapy combinations, or better yet on IO-IO combinations, and those are data that we've not yet seen. Secondly, I think we have to distinguish between blood TMB and tissue TMB. And it may turn out that blood TMB is a bit more reflective of the entire tumor as opposed to just a single tissue sample. And again, that's just my theorizing. But long story short, not ready for prime time.
So I totally agree that it's not ready for the prime time. I'm sure that we must go to the personalization of the treatments. It is possible that there will be a value for the single agent and also for the combination with the anti-CTLA-4, anti-PD-1, and anti-PD-L1. But nowadays, what we can do in the clinical practice is to select based with PD-L1 status, and chemotherapy plus immunotherapy is the only phase 3 that proved an increase of overall survival everywhere.
I have a question. So, question for the panel. So I know Dr. Rizvi is not here. In his presentation, his high TMB was 20 mutations per megabase. Fabrice's is 10. And then these other two is actually a completely different definition, 175 mutations per exome. And I think herein lies the problem. We are not even talking about the same thing. And I wonder if they can comment on that. I mean, normally in medicine, if we have a biomarker, an EGFR mutation as on 19 deletion, we are all talking about the same thing. You know, assay sensitivity might be slightly different, but we know what we are talking about. But if you tell me high TMB, I don't know what it means because everybody defines it as differently.
I pretty much agree with you, Alex. I think, remember, TMB is not the target of these drugs. PD-L1 is. and it's a surrogate, perhaps a surrogate for immune load for neoantigen. There are so many different ways to do it. NGS may not be as good as whole exome sequencing. Really, to determine TMB, you need a whole exome sequencing. And the blood-based markers, as I said earlier, may ultimately pan out better. But there is, as you point out, absolutely no consensus on which approach to use and what the cut points are.
Yeah, I totally agree. They are two different tests, but at a certain point we will need to harmonize the test if we want to introduce it in the clinical practice. The best, in my opinion, is the whole exome sequencing because the other one is different. But if you look at the cutoff, you can see that there is a benefit every time with the single agent with TMB high. You just increase the size of the magnitude of the effect as much as you increase the TMB. So I think that we have a lot of work to do.
Yeah, it's just a matter of sensitivity and specificity of the test you are looking for. It's a continuous biomarker. Then if you put the cutoff very high, of course you will select a patient population that will for sure or almost for sure respond to the immunotherapy, but it will represent only a very, very small part of the patient. And if you decrease the cutoff, then you have a more heterogeneous group with patients who respond. The selection of the patients is, of course, less evident. And it's why I think this kind of cutoff and the selection by the TMB is so complicated as of today.
Okay. Any more questions? If not, we are going to see the announcement of JTO Clinical and Research by Dr. Ajay.
Use the left click. No. Okay, so for those who are interested, what did I do now? If I can find this. Can you help me? So, after all the wonderful data are generated, they need to be published somewhere. And as you know, JTO is the official journal of IASLC, and the journal has really grown, and the impact factor has gone up. And with that comes a problem that's illustrated here. Last year, we rejected over 1,500 manuscripts. A lot of these were solid studies, well done, but because of the increase in impact factor, we just don't have the space to publish all the things that we are receiving. And we think that a number of these deserve to be published. As you know, lung cancer is growing, lots of studies going on, and so there's a lot of data coming that we need to publish. And so based on that, the decision was made that IASLC would introduce a second journal. And in thinking about that, we noted that these days, about 20% of oncology manuscripts are open access, hybrid and gold open access. The hybrid is what we have at JTO now, which is some articles are in paper only and some are open access. And then the open access journals are the ones that are completely online. But we note that for those of you in Europe, for instance, the new plan S would not allow funded authors to publish in subscription-based journals only, such as JCO, JTO, and so on. And with increased digitization, we think open access may become more prominent in future. So this new journal will be online only, owned by IASLC, published by Elsevier, our current publisher, and like all other open access journals, it will be funded through assessment of article processing charges from authors and open access, and with a lot of input from our publisher and so on, we decided on the name of JTO Clinical and Research Reports. It was felt that it was important to align this new journal with JTO, which has the recognition already. And this will be distinguished by, again, being open access and being more clinical, whereas JTO is clinical and translational. So we will publish phase 1 trials, which are in lung cancer only, well-performed phase 2 single-arm trials, retrospective studies, database analysis, and large institutional series. We are an international organization, and sometimes we get papers based on agents that are only approved in certain parts of the world. So for instance, in China, they have a checkpoint inhibitor, sintilimab, which is approved only in China. They have a VEGF inhibitor, fruquintinib. Rubicin, which is used in small cell, is only approved in Japan. And now, when we get papers with these drugs, because of our large readership, it might be meritorious, but we struggle with publishing it because most of our readership don't use these drugs. So all such journals would be, all such manuscripts will be published in JTO clinical and research reports. In terms of timeline, we plan to have the first edition out in first quarter of 2020. And in the first year, we plan to publish 4 issues, so it will be quarterly at the first year, and then the second year onwards, it becomes more frequent. And so I'll stop here. Questions, if there are any?
I would like to highlight the excellent impact factor of the journal, of our association, so congratulations for that, Alex.
Yeah. One thing I didn't mention, as you probably know, the open access field is fairly murky. There are journals out there that will publish anything. And the idea is because the authors pay a fee to get their papers published, there are some of these journals, once you're willing to pay, they'll publish it. And some of them take the view that the readers should judge which manuscripts are good or bad. And we don't aim to do that. So the first thing is that we aim to publish good quality papers. So initially, we presume that a number of manuscripts will be studies that are well done, which just because of space constraints, we can't publish in JTO. The author will be given the option of publishing this in JTO CRL. And so we aim to, in very short order, be able to get a reasonable impact factor, because we'll be publishing good articles, not just anything that gets submitted. Question?
There's no risk. There's no risk of dilute quality of the JTO by adding these new options of publication.
Your question is if there's a risk?
There's no dilution of the quality of, and maybe a negative even effect on the impact factor by extending the options for publication.
No, we don't think so. I think that if anything at all, probably strengthen JTO, because authors now have a couple of choices. So as you probably know, almost every author aims for the highest impact factor journal they think their manuscript will get into. So I don't see this as actually diluting us. I think it will actually strengthen us in the sense that we'll get more manuscripts in and we'll publish the high impact ones, and this will be another option for those that don't make it to JTO.
Any other comment? If not, thank you, Alex.
Thank you.
Marina, Fabrice. Thank you all of you for being here, and have a good meeting.
Thank you.